Hey guys, welcome to another one of the 4 videos I'm creating for neonatal ventilation. This one is a little different. This one is neonatal non-invasive ventilation. Um, Again, these presentations are meant for new respiratory therapists in the NICU, respiratory therapy students, or new nurses in the NICU, or just anybody that feels like listening to my voice. I wanted to touch on non-invasive ventilation because it is something that is very, very much growing in popularity, both in all parts, let's just say all parts of the respiratory community. Um, we've seen a lot of improved outcomes. We've seen a lot of good come from non-invasive means. So you will be setting up mostly non-invasive in your career, so much of it. So let's learn a little bit about it. Okay, lecture outline. Again, I like to kind of know where we're headed, and you guys probably like to know where we're headed with these lectures. So we're going to talk about indications and contraindications, Nippy, CPAP, high flow, and then equipment management and interface management. So what is non-invasive ventilation? Unlike any high-frequency oscillatory, high-frequency jet, and conventional ventilation, which are all delivered through invasive means, non-invasive ventilation is positive pressure provided through non-invasive interfaces. We're able to support both oxygenation and ventilation through non-invasive means. We can provide either pressure or flow, depending on what is needed for the patient. And it is very much growing in popularity. It's very much being pushed. And then it is also very well tolerated. It's better tolerated than invasive ventilation by a long shot. So indications would be increased workup breathing. Maybe you have a baby that is grunting, flaring, or tracting, any of those excessively tachypnic due to pulmonary issues would all be indications for increased workup breathing. We can use this for transitional support, so that transition period after delivery and getting our lungs nice and inflated where they need to be after being born. Prevention of respiratory failure. So if you see a kid really working, hopefully we can prevent the true respiratory failure by addressing increased respiratory effort. If we have extended non-invasive support reasons, like maybe we are able to extubate a chronic kid, or we have a kid that is doing fine, has great volumes and everything, but we just want to help them out. Maybe they're just very little, but they don't need to be intubated. And then we can use this for both long and short-term use. We can use it as a matter of minutes at a delivery or for a while a baby works on growing. Some contraindications would be impending respiratory failure, which defined as the CO2 continues to rise despite increasing ventilatory intervention. So if you're continuing to go up on your PEEP, if you're continuing to go up on your rate, and we're still just CO2's climbing, we're not doing well, our color isn't great, those are signs of impending respiratory failure, and you want to intubate, and non-invasive would kind of just be holding our spot while we set up to intubate. Excessive emesis or oral secretions. This would be to prevent any type of aspiration that could go into the lungs. Aspiration just hammers the lungs. So if we have tons of puking or tons of oral secretions, intubation might be the best move. And finally, apnea. These are non-invasive means, so you have to have your own spontaneous respiratory effort in order to use these ventilation strategies. So to start out, we're going to discuss non-invasive positive pressure ventilation. You'll also hear it called Nippy. This is similar to, if you have worked adults and are coming to neonates, similar theory as BiPAP. But these are babies, so you have to run it a little differently. But similar theory. We are using 2 pressures. We have our IPAP or our PEEP, which are the same thing. This is the pressure applied to inhalation that helps support or increase that breath or that non-invasive tidal volume. Our EPAP or our PEEP is pressure applied on exhalation. This helps with alveolar recruitment, which therefore supports oxygenation. And again, remember, ideal gas exchange occurs when we have the right amount of surface area with the right amount of pressure. Different ranges. Typically, your IPAP, you start between 12 and 30 centimeters of water pressure. I've kind of found 15 to 20 being a good range to start. EPAP, 5 to 12, again, depending on pathology or what's going on. If you have a kid that just kind of needs a little bit of a boost, you'll probably have a little bit lower PEEP, like 5 to 8. But maybe we have a chronic kid that we're kind of just chugging along with. They'd be more appropriate with the 10 to 12. Also, in relation to FiO2, you can increase your EPAP depending on your FiO2. I time, we'll either have between 0.5 seconds or 1.5 seconds, and this is dependent on rate and strategy. So if you have a rate of 30, you're not going to have a 1.5 second I time, or else that's not going to allow accurate time for exhalation. But if you have a rate of 10 and you're just working on recruitment or hopefully transitioning from Nippy to a CPAP, you can give a longer I time, such as 1 second. I found that most of the time 1 second is a great place to start, and then I can adjust up or down from there. So some more pictures. So Nippy, here is our PEEP, and here is our set PIP on this first breath. So we go up, it delivers up to that pressure, and then we exhale down to our set CPAP or PEEP. So CPAP, EPAP, and PEEP are all the same. It's just they can be used interchangeably, and some people say PEEP is only for invasive, but they're all the same theory. Okay, so our next breath, moving from this is our original breath. Let's say we have CO2. We have a high CO2, so we need to blow off more CO2. We need to increase our PIP. So to increase our PIP, we increase that delta P, which again is our change in pressure. So the difference between our PIP and our PEEP. If we increase that pressure, we'll increase that volume we're exhaling. So we'll be increasing that tidal volume in order to blow off more CO2 to decrease our CO2 to an ideal range. That's how and same with inverse. If, say, we have a low CO2, we can bring that pressure down to help increase our CO2. Let's say we have a low O2. So a good rule of thumb I go by is if my FiO2 is increased by 20% and we're consistently staying at 20% or 60% or greater, then I need to consider increasing my EPAP. So again, if my FiO2 is increased by 20% or more and staying, or if my FiO2 is consistently above 60%, I absolutely need to increase my pressure. Sometimes with neonates, even if it's above 40, and I'm like, you shouldn't be above 40, what's going on? I will increase my end expiratory pressure. Remember, Nippy is a direct measurement, so it won't compensate. So if you increase, say this is our breath, this is where we started, we increased our PEEP. You'll also need to increase your PIP a little bit because we'll have that smaller delta P, and your CO2 might increase because we have a smaller tidal volume, a smaller change in pressure. But that is good for oxygenation. So if you increase your PEEP, also increase your PIP the same or more if your CO2 is high. Okay, CPAP. This is I feel like I've built my career on CPAP. Continuous positive airway pressure. This is one continuous pressure applied on exhalation. It's what you hear your grandpa use at night. But in the neonatal world, we use it for alveolar recruitment, help decrease that work of breathing. It helps basically the baby catch their breath. We can use it to support adventitious upper airway anatomy if something's not right. Help decrease alveolar surface tension, again, so we're preventing those alveoli from coming together and sticking and then ripping back apart to prevent that hyaline membrane damage. And then because we are applying pressure on exhalation, we can improve oxygenation. Starting out for non-invasive purposes, 5 to 9 centimeters water pressure. I'm a very strong believer that you don't go below 5. I will roundhouse kick you in the head if you go below 5 centimeters water pressure. FiO2 21 to 100%. And then again, consider increasing pressure if FiO2 is 40 to 60% and continuing to climb or staying consistently. If we're having high FiO2 needs, it's absolutely appropriate to consider increasing pressures to help open up those lungs a little bit more and allow for oxygenation to occur. CPAP, basically we're increasing the pulmonary baseline. So on our little diagram here, this is our natural intrinsic PEEP. Natural, normal, on a normal set of lungs, intrinsic PEEP is about 3 to 4 centimeters of water pressure. If we add CPAP, we are adding additional pressure on top of that intrinsic PEEP. Sometimes that intrinsic PEEP can be inadequate, and that's when we get atelectasis. So here's our little collapsed alveoli. He's closed off. He's not doing so good. If we add PEEP, we allow for alveolar recruitment to allow for those alveoli to open up and proper exhalation to occur. Hey, this is a big one. High flow nasal cannula. This is a very, very popular piece of equipment. So this is, again, universally in the respiratory world, high flow is a very well-tolerated form of form of equipment in therapy that does a lot of good, and a lot of patients will really tolerate well. So this is continuous flow, which helps stent open the airways. We can't call it PEEP because we're not measuring it with a pressure, and we can't really say we have a set pressure. But it helps stent open the airways. It provides humidity. We can even give relative humidity. We can support inspiratory efforts because we're applying pressure that it can support that inhalation. And then it flushes out dead space ventilation so that instead of having just dead air floating around in the major airways, it can be beneficial with certain oxygenation and help flush out that dead space that might not be beneficial in our lungs. It can be used for longer periods of time on lower settings with a swallow eval and physician consideration. If typically 2 to 3 liters, a baby can actually feed on high flow, which is a game changer. We deliver both FiO2 and flow, and then our goal is to decrease work of breathing. For neonates, we want to go between 1 and 8 liters per minute, with the set degrees at 34 to 37 degrees centigrade. Equipment management. So there are multiple variations that can be used to deliver our support. I'm just going to show you some commonly used equipment. Again, there is a wide variety of equipment and different things that can be used. So this is a little snippet. It's not exhaustive of what can be used for delivering. So we're going to focus on the Draeger, which can provide non-invasive modes such as Nippy and CPAP both. So that's kind of nice. Say we extubate our baby, we can immediately put them on Nippy or CPAP using the same piece of equipment. The Vapotherm and bubble CPAP. So here's the Draeger. We can even use the same circuit. You just take the proximal flow sensor out of line. Put it in a little baggie because maybe we have a kid that might get reintubated. We don't want that flow sensor just flopping around and getting gross and dirty. So put it in a bag, put it where it's safe, because you're not going to need the proximal flow sensor in a non-invasive. We can provide both Nippy and CPAP, and this is found in the ventilation settings. So my RTs, if you are going from an invasive mode, say, and then we're extubating, you have to put the Draeger in standby before you can switch it to a non-invasive mode. So remember, if you're going from invasive to non-invasive, you have to place it in standby for that to occur. Over here you can see once we're in that standby, in that non-invasive mode, we have CMV, which is our Nippy setting, and then CPAP. So it says spontaneous CPAP and pressure control CMV. That is the Nippy CPAP. It would be a CPAP mode. Down here, and then you can see NIV right here, and this orange box will indicate that we are in a non-invasive mode. Also, that we don't have the flow meter in line. This is saying no flow meter. So we have our FiO2, our PIP, this one's at 24, our I time, our rate, our PEEP, and you can set a slope, but most of the times in non-invasive modes, it doesn't really affect ventilation all that much. So we put our settings down here, and then we get some readings up here. So our, and that's just what is being fed back to the machine through our exhalation line, through our exhalation circuit. But it's not as accurate as invasive, but it's there to give a good job. This is the Vapotherm. It's a good piece of equipment. Over here we have our liters per minute, our FiO2, and our temperature. And really, all that changes between this one and the adult is the inner cartridge, so that it can program it for whether it be neonatal or for adult. So the neonatal will go from 1 to 8 liters per minute, and it will go up by half. So you can have like 3, 3.5, 4, 4.5. FiO2 21 to 100%, and then temperature 34 to 37 degrees. If you want to make a change, this is your select button. You can select until you are on where you want to change. So let's say you can select until one of these is flashing, and then turn the knob. This will turn left and right to where you want it set, and then it will automatically set. You can either leave it and it will set it, or else you can just press the select button again and it will confirm that setting change. We have the silence button, and then this is the start button. So after you get everything going, that will start. Just a little bit of learn from my experience. Make sure the water is spiked up here and your cartridge is in and your water is spiked and everything before you plug this in to electricity, because otherwise it will kind of freak out and not get happy with you. So spike the water before you plug in. Bubble CPAP. So these pictures aren't the greatest. I apologize in advance, but this is a common setup for bubble CPAP. At the wall, you have a blender, and they are connected to the air and oxygen 50 psi into the wall. On one side, you'll have your emergency equipment set up. So a 15-liter flow meter, because I have my equipment set up to a Neopuff, and I have a backup NeoT. Use what is set at your facility. But we have a 15-liter flow meter attached to our blender, so we can use it in case of emergencies, in case we need 2 bag. On the other side, I have screwed on a 15-liter flow meter for my CPAP. This is where I will adjust my FiO2 ranges to wherever it needs to be. I run bubble CPAP between 12 to 14 liters per minute in order to provide accurate flow and accurate pressures. From the top, this is the best angle to show you guys. This is our setting dial. This little arrow kind of shows this will show what our setting is. And then we fill it up to this line. I'm literally using centimeters of water pressure to provide CPAP. So we fill up to the line, and this automatically has measured for me our centimeters of water pressure, which is kind of nice. In it, there's also a little straw I'll try to point out, and if I get condensation built up in here, I can withdraw or add water, depending on, to make sure I'm getting accurate pressures for my baby. Also, that oscillation comes from the bubbling is beneficial for little immature alveoli. Okay, this one has kind of a lot going on. So we'll start from one end and go to the other. Here is our inspiratory coming to the patient. This is our concha heater to provide heat and humidity. We set it at 37 degrees. And you want it on the driest, or else you're going to get a ton of rain out and you're going to lavage your baby. Right here is the T-piece that allows for flow. So we have our T-piece here. We have our oxygen tubing right here, providing 12 to 14 liters of oxygen that is titrated based off the wall blender. This is a pop-off that is set at 12 centimeters of water pressure. So if our pressure is climbing for whatever reason, it will hiss, and then it will alert you that you're getting up to 12 centimeters of water pressure. The other is the oxygen analyzer that goes in on the other side to help close off this system and allow us to read what we are actually delivering to our patient. Here's our water chamber. And again, our line, we will fill up the water. This blue cap twists off. And then our setting dial. And then our expiratory tubing that actually provides pressure for that baby to breathe against to help aid in alveolar recruitment. So those are just kind of the main non-invasive pieces of equipment. Next, we're going to talk about delivery interfaces. And again, this is not an exhaustive presentation. We're going to mostly talk about ram cannulas for pressure and high flow nasal cannulas for flow. So finding the best interface for the baby and for equipment being used is important with delivery. Don't underestimate how important interfaces can be. But also flow and pressure require different cannulas. Every time you go to check your equipment, check your baby, we want to prevent skin breakdown over treat skin breakdown. So always make sure you're assessing their septum, their upper lip, underneath where the cannula is sitting. We don't want to cause breakdown. Inside the nair also. When you're trying to find the right size cannula, you need to assess the septum size and then also the size of the nair, both. Appropriate occlusions, high flow nasal cannula, 50% occlusion, and CPAP and NIPPV, 80% occlusion is ideal. This allows for both a little bit of exhalation and also prevention of skin breakdown. I'm sure there's like some trick, but it's use your best judgment. So with the RAM cannula, I'm sure other facilities have different ways to do things, but this is my way, so it's my correct way. Use it as you wish. So here are the supplies we need. Two, I call them my little jelly beans of Duoderm, and that's so that it can fit and cover the front of the cheek and the back of the cheek, but also have a place so that the eyes aren't covered and squished. One Tegaderm, and I cut it in half. Alcohol wipe and skin prep of your choice. Again, I'm a huge believer in the 3M skin barrier film, or you can call it a lollipop, whatever you want to call it. Oh, it's the best thing on the planet. RAM cannulas come in various sizes, and it goes by size, and you can kind of do your best guess based on gestational age. We hardly ever use the white. That's for like super tiny preemies, and then the sizes go up from there. So most of the time you'll use the orange for term kids and the blue for maybe 34-ish weekers. But assess for the nair occlusion, because you want to also give that baby the best option you can. You don't want to go too small. They're not going to be appropriately managed, but you also don't want to go too big to cause skin breakdown. Okay, here's my little, I didn't have a real life baby to show you guys this on because of HIPAA. So we've chose the size of our RAM cannula. Okay, we found the appropriate size for our nair. Next is to prep the skin as you wish. So I like to rub it with alcohol and then use a skin barrier because I feel like it protects the skin from adhesives, and also it makes it sticky so it lays nice. You place your little jelly beans on either side of the nose and having them tilt upward because the eye is supposed to fit here, and this goes right next to the nair. Do not tape these in the hair. It's my pet peeve when I come in and it's just like not anywhere near the nose. It's supposed to be on either side of the nose and tilted upward. It's not in the hair. If you choose to put in what's called a septal H, I only ever really use these in more chronic kids that are on high pressures for non-invasive means for long periods of time. What it does is is a specially cut duoderm that can go below on top of the lip, pass through the septum, and then over top the nose here. And that's to prevent breakdown on the lower lip and the septum. It's easiest to do that before you secure it down with Tegaderm. After that, you take the Tegaderm halves and you lay them long ways across here. Across your cannula, make sure it's in the middle and slightly upward. It makes it lay nicer. It'll make it prevent from coming out of their nose as much. And then if you use alcohol wipe, you can vacuum seal it down. It causes some type of reaction, and it vacuum seals it down so that it looks nicer and it lasts longer, and you don't have to go so long between retaping, and it makes your baby look nice. High flow nasal cannula comes in 4 different sizes. The best method is to assess septum size for accurate cannula size. This one is more, think RAM is more size of the nair, high flow is more septum size. The end here connects directly to the small bore circuit of the Vapotherm, and that's why you need the specialty cannula over just a normal nasal cannula because of these attachments, and it's shorter here. We use tender grips to secure, so just like you would with a nasal cannula, little tender grips, just immediately back from the eye onto the temple is the best location. 50% air occlusion, and then based on the septum. These are just kind of a little snippet of interfaces, but I hope that was beneficial. Okay, and thank you guys for everything. Thank you, Draeger and Vapotherm, for letting me represent your products on this educational presentation. And look at this dog, how gross. I was eating popcorn. She wanted some. Okay, again, please reach out if you guys have any questions or need anything from me. Hopefully I'm pretty available to you guys. Thanks so much.